Hello, welcome everyone. Um, this is part one of our three-part series, Improving Cancer Care for Rural Communities. My name is Nora Billy Barnett, and I am a health professions outreach specialist at the network of the National Library of Medicine, Region 6. I will be the host today. I'm joined by my colleague, Jacqueline Leskovic, who is going to be assisting with the technical side of things. The title of today's session is Addressing Rural Cancer Care Through a Network Model. I'm pleased to welcome Erin Seaman, PhD, as our guest speaker, whom I will be giving a more formal introduction to in a moment. Before we begin today's session, I want to cover a few logistics. So you will see a chat box. On your Zoom screen. And we ask that you please use the chat box to share your comments and questions, which we will address at a Q&A session at the end of the presentation. So feel free to use that chat box for any comments and questions, and Jacqueline and I will be keeping an eye on that. Closed captioning is available by clicking on the icon with the three dots at the bottom of your screen. Just a note that we do not have a live captioner today. However, the automatic captions are enabled. If you need support or if the captions are not sufficient, please let us know using the chat. The session is being recorded and it will be available for your viewing within 2 weeks of this presentation. And lastly, continuing education is available. I'm very pleased that today's session offers a number of types of continuing education, including certified health education specialist, contact hours, certified nursing education, and medical library association credit. At the end of the recording, we will provide a link to an evaluation. So fill out that evaluation and you will be able to claim your credit. A word about the host organization. This webinar is hosted by the Network of the National Library of Medicine, or NNLM. For those of you not familiar with the Network of the National Library of Medicine, NNLM, we are part of the National Library of Medicine, the world's largest biomedical library, which is one of the 27 institutes and offices of the National Institutes of Health. NNLM is comprised of 7 regional medical libraries, as well as various offices and centers, such as a public health coordination office and a national training office. We offer educational opportunities like this webinar and different classes, and sometimes we even offer funding opportunities. With that, I would like to bring you to today's programming. Our guest speaker is Erin Seaman, who I am thrilled to introduce. Erin is an assistant professor at the University of Iowa. He holds a primary appointment in the Carver College of Medicine's Department of Internal Medicine and a secondary appointment in the College of Public Health's Department of Community and Behavioral Health. As a medical anthropologist and implementation scientist, Dr. Seaman seeks to improve cancer care and patient outcomes through research that identifies the challenges and intervention opportunities in local cancer care delivery contexts, focusing much of his work on issues related to cancer survivorship. On the Iowa Cancer Affiliate Network team, he supports the evaluation of network implementation, focusing on the process of building the network and the impact of contextual differences across affiliate sites. And with that, I am going to hand this over to Erin. Thank you for being with us, Dr. Seaman.
Excellent. Thank you so much, Nora. And thank you, Jacqueline and the network of the National Library of Medicine for the opportunity to talk today. I'm really excited about it. I'm going to go ahead here and look to share my screen, although it looks like I need screen sharing access. Okay, great. I want to make sure you see the right screen at the moment, not the presentation one. Excellent. So as Nora said, I will be talking today about addressing rural cancer care through a network model. I have no disclosures. This research is supported by the National Cancer Institute of the National Institutes of Health under an R01 award. I should say that the content is solely the responsibility of the authors and does not necessarily represent the official views of the National Institutes of Health. So our plan for today is to discuss a little bit what it means to be rural in the US, describe disparities in cancer incidence and outcomes affecting rural populations, discuss some challenges facing rural hospitals and patients, and explore potential solutions to rural cancer disparities. The learning objectives, which I want to point out too, and I'll come back to that in a minute, that we put forth for this webinar are as follows. Describe the unique challenges faced by health professionals in delivering high quality cancer care in rural settings, including limitations in infrastructure, specialist access, and care coordination. Explain how the Iowa Cancer Affiliate Network enhances rural cancer care by supporting the implementation of evidence-based standards, improving multidisciplinary collaboration, and increasing adherence to treatment quality measures, and evaluate the scalability and early outcomes of the ICAN model and its potential to improve cancer care delivery and reduce disparities in rural regions across the US. And with that, I want to start with a picture that very much looks like much of Iowa, where I am located. Somewhat an idealized version of rurality in terms of you see a farm and rolling hills and some early crops there, it looks like. And I want to talk about that sort of in relation to this. This is the graphic that was designed by the Prevention Research Center of Rural Health. The Prevention Research Center of Rural Health is at the University of Iowa. It's a CDC funded prevention research center. And I'm interested, and I move from that image, from this image to this one. In order to move in and think a little bit, I want to focus on the illustration, which was developed in collaboration with members from rural communities across Iowa, with whom the PRC partners. The community members were committed to an illustrated version of rurality that was not just the rolling fields of crops, but also a range of housing and job opportunities you'll see, ages, races, ethnicities, activities, and resources. They wanted an image that captured the complexity of their lives. As Rima Afifi, who is the director of our Prevention Research Center here, and colleagues have written, place matters. Place can create equity or inequity. The representation of place is not neutral, but rather the result of complex political and social processes and choices centered in power and privilege. Narratives of, quote, rural places represent this complexity as they have been constructed from a metro-normative, urban-centric perspective. Dominant representations of rural places suggest a singular deficit-based place. Yet rural places are nuanced, thriving places where people are born, learn, live, work, play, worship, and age. Understanding the complexity of rural is critical to the development of more responsive social and health policy and services that promote health equity. And I start with that because one of the learning objectives for today, as we just noted, was to describe the unique challenges. And while it is true that we'll discuss some real challenges for rural communities and those who serve them in terms of cancer disparities and the work to provide comprehensive cancer care, I also call upon us to remember that the solutions are fundamentally rooted in rural strengths, in the resourcefulness and creativity of rural providers, and that it is this strength and creativity that network models such as the Iowa Cancer Affiliate Network look to support and enhance. So with that, we'll talk just a little bit about rurality and how we think about rurality. One of the most common used ways to define and categorize rurality, and one that is used by the NCI, the National Cancer Institute, is the U.S. Department of Agriculture Rural Urban Continuum Codes, or RUC. These occur at the county level and distinguish metropolitan counties by population size of their metro area, and non-metropolitan by their degree of urbanization and adjacency to a metro area. There are 9 codes, and within the 6 non-metro codes, the 3 least populous categories are considered the most rural. So if we look at a map, you can see the spread across the US here, the distribution of metro, non-metro, and rural counties, with the rural counties being those in those last three categories. You can see that rurality is not uniformly distributed across the US, with the Midwest and West having some of the largest contiguous areas of rural countries. It's important to understand that although there are some commonalities across all rural communities, not all rural areas are the same. And so, for example, the rural South is very different from Appalachia, from the rural Midwest, the Southwest, and the frontier Northwest. This means that solutions to address disparities need to consider local context to be successful. Thinking about cancer, people living in non-metro or rural areas have a lower overall incidence of cancer. You can see in this slide to the left, this graph to the left, but a higher mortality rate. And mortality rates, as you see on the right here, are not declining in those areas quite as quickly as they are in metro areas. So the gap is widening in terms of cancer mortality. We see that looking at evidence that suggests that some of the cancers are more common in rural areas, whilst others are more common in urban areas. Among the four most common cancers, lung and colorectal cancers occur more often in rural populations. The elevated incidence rate of lung cancer in rural areas can be attributed to higher rates of tobacco use, while the elevated incidence of colorectal cancer rates are for the most part attributed to obesity and lower adherence to cancer screening. Although as we continue to find out these, the factors influencing cancer rates are increasingly complex. Death rates for the leading causes of cancer death, lung, colorectal, pancreatic, and breast cancers, are all higher in rural areas. Disparities in death rates between rural and urban areas are larger for lung and colorectal cancers and comparably smaller for breast and pancreatic cancers. Rural disparities in cancer mortality appear to be worsening, likely due to the effects of rurality on access to cancer prevention, diagnosis and treatment services, as well as the higher prevalence of some risk factors in these areas. However, the difference in mortality is likely related to access to care, including less prevention and diagnostic services. So in this 2018 study of approximately 36,995 patients enrolled in clinical trials over 37 years, patients from rural areas with a wide variety of cancer types had similar outcomes compared with their urban counterparts when enrolled in clinical trials. This finding suggests that improving access to uniform treatment strategies for patients with cancer may help resolve the disparity in cancer outcomes between rural and urban patients. However, there are several barriers to increasing access to cancer care in somewhat traditional ways of how we think about increasing access. So there are barriers to the centralization of cancer care, including the burden of traveling for cancer can be too great. Patients often prefer to receive cancer care closer to home, and patients heavily rely on recommendations from the doctors on where to go for treatment. And they often don't know that they should consider going elsewhere for treatment. And so they are diagnosed in a clinic or hospital in their local community and then not referred to a more specialized cancer clinic elsewhere. In work that we've done, we've identified challenges at both the hospital and provider levels to providing cancer care in the rural setting. Rural hospitals, more than urban ones, suffer from the financial constraints of operating in a low volume, high fixed cost setting, and are more likely to have workforce shortages. They also serve an older, less healthy population, often with an unfavorable payer mix. They often do not have infrastructure for data collection, which makes quality monitoring more challenging and improvement based on that monitoring. And when asked about their challenges, rural cancer providers describe both limited primary care services as well as a lack of subspecialty providers. Fragmentation of care is a common problem when patients receive treatment at multiple facilities, but there is an increased need for, but less resources for patient navigation. There's limited access to clinical trials, and providers at all levels tend to have a fairly wide scope of practice, but often have limited resources, including time to stay up to date on guideline concordant care. So one way to think about addressing this challenge is the network model. In 2006, the University of Kentucky Markey Cancer Center built a collaborative affiliate network, McCann, with hospitals across Kentucky, many of which were in rural areas, to improve quality of cancer care. You can see the map there with UK in the center and sort of the satellite hospitals and affiliate hospitals located around it. As part of their program, which grew organically over the course of several years, they developed tailored programs and resources for affiliates. They encouraged affiliate sites to refer complex cancer cases to UK and then referred them back for adjuvant treatments when appropriate. They leveraged accreditation standards of the Commission on Cancer to improve quality and required accreditation for affiliate sites within 3 years of joining the network. And they provided accreditation support to achieve this. 12 out of 13 hospitals achieved accreditation over the 3-year period after joining the network, and hospitals that joined the network had an improvement in performance on 3 out of 4 cancer-specific quality metrics that are measured through the Commission on Cancer standards, and better performance than matched control hospitals by the end of a 3-year period. The Commission on Cancer standards became a central part because of accreditation. Because if we look at this, if we go back, one of the things that University of Kentucky Markey Cancer Center did was to incentivize participation in the network model was to allow affiliate sites to use their marketing and branding in order to increase their visibility in the community in terms of cancer care and hospital care. But with the branding being used by the affiliate sites, they wanted some way to ensure the quality of care at those sites as they began working with them. And so they used the Commission on Cancer as a tool to do that. The Commission on Cancer standards address the full continuum of cancer, from prevention to survivorship and end-of-life care. And they address both survival and quality of care. For those who don't know, the Commission on Cancer standards, it's an accreditation program designed to promote comprehensive evidence-based cancer care through measurement and quality improvement. And for over 100 years, the American College of Surgeons Commission on Cancer has assessed their accredited hospital cancer programs on a number of evidence-based, guideline-recommended quality measures. And so McCann used those measures as a means of ensuring the quality of their affiliate sites and required accreditation of those sites. If we look at the rural and urban differences in COC accreditation, you can see here that there are a number of COC hospitals, and yet they are located primarily in metro areas. If you take out, so the map on the left has all of them, all of the COC hospitals, and if you take them out on the right there and just have the COC hospitals located in non-metro, urban, and rural counties, you see that there are many fewer. And they are particularly located in the eastern half of the US. So we chose to conduct a program to look at the implementation of a network model based on the McCann model. And we applied for, Dr. Charlton, who is the PI of the grant, applied for a grant through the National Cancer Institute that was to codify the elements of the McCann model, determine the core functions of the model, and document the specific strategies or activities that may be customized to Iowa and that are needed to carry out the functions. Then adapt those core functions to our context in Iowa, implementing a collaborative network adapted for Iowa to make achievement of the COC standards more feasible for our rural community hospitals here, and then measure progress towards achievement of COC standards and impact on quality measures. We are about 4 years into that 5-year program. So I will go ahead now and talk about what we've done across that time and how we identified the core functions of McCann and what we've done to implement that here. So the core functions you can think of as the underlying mechanisms of change that make an intervention effective. They're the components that are necessary and sufficient to compose the intervention itself. And so when you're looking at an intervention in one setting and looking to adapt it to another setting, you want to make sure that you have the things that make that intervention possible when you're translating it, because you'll have to adapt a bunch of other things around it to fit the local context. So it's essential to preserve those core functions while adapting the forms, the various forms those functions take to a new context. So we first developed, in order to do that, we developed a document outlining every intervention that McCann performed on its affiliate hospitals and with its affiliate hospitals. And details of that included the purpose and role of each aspect of the intervention, the aspects of the intervention that were essential to its success, the purpose of the intervention, and the methods and conditions necessary to implement the various functions and forms. Our study team reviewed the document for accuracy and clarity, and then we incorporated feedback from McCann's medical director, administrative director, quality director, and certified tumor registrar. We ended up identifying core functions that fell into 4 key themes. The first involved the relationship between the hospitals and the networks. Hospitals felt that McCann understood and cared about their specific goals, not just about getting them accredited, and that improving patient care was a shared goal between partners. Secondly, McCann not only provided expertise on the COC standards, but also gave them substantive assistance in implementing them. They acted as champions for COC accreditation at all levels, helping programs understand how accreditation could help them meet their goals. We found that a key challenge is getting alignment of support between administration of the cancer program, administration of the hospital, and clinician support, and that you really need all 3 of those key support and buy-in for the project of achieving accreditation and working toward achieving accreditation. And so McCann really provided support to make that happen. Thirdly, McCann was also very successful in fostering a culture of data-driven quality improvement and collaboration, both within the institution and throughout the network. And finally, McCann provided services to the hospitals and their patients that they would not have access to locally, including clinical trials, education, and mentoring for clinicians and for other providers. So we took those sort of 4 groups of core functions and looked to bring them into Iowa. To do so, we first identified a number of hospitals that could be our pilot hospital sites. Across the state, we identified 4 initially. You'll see them there. They're in the red circles. They're the ones that are square. They're Spencer, Carroll, Burlington, and Clinton on the eastern side of the state. As we've built the program across the years, we have been approached by other hospitals to be part of ICANN. So the hospital there in Oskaloosa first approached us, and they are a critical access hospital. And I will say they have taken off in terms of their move toward accreditation, which has been really exciting. And then recently down here in the far southwest of the state, Shenandoah has approached us and begun working as part of the network as well, which is really exciting to see that portion of the state engaged as well. So amongst those 4 hospitals and then the hospital in Oskaloosa, these are the sort of pilot hospital characteristics of those that were included. And like to note that bed size and cancer volume do not correlate directly, which can make it difficult when looking from the outside to know which hospital's area are appropriate to target for accreditation. You can also see that most hospitals have only 1 medical and 1 radiation oncologist, except for hospital number 3, which has 2 medical oncologists who both work for a large nationwide practice and both work part-time at that hospital. Employment is through a variety of models, with all of the hospitals having at least 1 provider contracted from a larger hospital or group not based in that community. And I should note, in terms of cases, we restricted eligibility initially to hospitals that had a case volume higher than 100 analytic cases annually, to be able to get the volume necessary to sort of think about improving those cancer services and having a volume of cancer services within the hospital and the cancer program itself. So what did we do? So we took the ICANN forms, or the McCann forms, which are here on the left. You see the core functions, in terms of providing expertise about COC standards, providing a plan and framework, helping to establish that culture of data-driven quality improvement, those sorts of things. And then different forms or strategies of intervention that those could take in that second column. And then we started to think in terms of moving across those columns to bring the intervention to Iowa. What are the contextual differences between McCann and ICANN and the network we were looking to build? And as a quick example, one of the key ones is, if you'll remember the map of Kentucky with UK and the affiliate sites around it. UK is really in the center, and it's surrounded by the affiliate sites. So it has a nice sort of centralization, both in terms of access, but then also in terms of visibility and presence within the state. That looks very different from how that looks in Iowa here, where we sit on the eastern portion of the state. And there are several large cancer centers that surround us in terms of, in Omaha, Nebraska. There's Mayo just to the north in Minnesota. And there are cancer programs in Des Moines as well, in the western part of the state. So those kinds of contextual differences really shape how we approached our relationships with hospitals here. So those were the sort of contextual differences that we were thinking about. And then we thought about adapted forms that might be possible to address those contextual differences in bringing ICANN together. So we did that across a long implementation process that started with a site visit at each of the hospitals, where we went and spent a day meeting with folks and talking about our plans and our thoughts for what McCann had done and how we could bring that to Iowa, and getting their thoughts on what might be possible and useful for them, what their cancer programs looked like. Then we conducted a series of gap analyses that involved talking about each of the standards, the COC standards, and then evaluating the individual hospital programs, the cancer programs, capacities and current resources for those standards. So we did a series of 3 of them. We looked at clinical services, and that was primarily with administration of the cancer program. And then we looked to engage clinicians and familiarize them with some of the specific COC requirements that would really affect them. And then in the third analysis, looked to review physician-specific standards. Then, once we completed those analyses, we went back and pulled together a proposal for a 3-year plan to move toward accreditation that included, as listed there, some strategic planning, some thinking about how to do that over the 3 years, how to build ongoing accreditation support on our side to provide them the support and resources necessary to bridge that, thinking about educational opportunities that might be useful, and then really working to build that data collection infrastructure. Because remember, the COC standards and the mindset behind that is that access to data about how your program is doing is the way that you can understand how to target and identify opportunities for quality improvement. So it's really based on that. 4 out of 5 hospitals from the initial series completed the gap analysis and are completing year 2 of their implementation currently. So the COC standards that we went through with them address institutional structure, credentialing, cancer-related services, clinical trials access, quality improvement, and data collection and monitoring. There's a number here. There's 9 groups and several underneath them, and I'm not going to go through them. But these are the standards that we walked through with everyone during those gap analyses when we were looking to identify where key places for support were. So our gap analysis findings were that the sort of key challenges initially were to data collection, which was a big one. Very few data collection protocol were in place at the hospitals we worked at. There were a number of staff shortages actually across the 5 years. We've seen a lot of variation and turnover in staff, which has greatly impacted different cancer programs' ability to participate at different points. Access to services like genetics, palliative care, survivorship really varied across programs. And then access to clinical trials. Being able to enroll, if you look at 9, clinical research accrual is a key standard of for the COC standards. And that is often a challenge for rural hospitals, especially because it's not just based on the referral, but it's based on enrollment in a clinical trial, which they often have very little control over. So we came up with a number of interventions to externally facilitate and support the hospitals that were participating. In terms of data collection and analysis, we are uniquely situated here in terms of the Iowa Cancer Registry, which is housed within the University of Iowa. And Dr. Charlton, who is the PI of this project, is also the PI and the director of the Iowa Cancer Registry. And the way the registry is set up here, it provides strong support to hospitals across Iowa. And so we were able to extend that to these hospitals as well. So we have been working to train cancer tumor registrars within the sites, and also providing support to do the registry abstraction while they are building up the staff and building up the capacity to be able to hire a tumor registrar if they didn't have one. We provided site licenses and cancer site reports back to them as well with their specific data to be able to provide some insight into their quality metrics. We provided accreditation support, including regular meetings, a website with specific resources, templates, in terms of policy and procedures, in terms of other tracking for cancer committees. And then some pretty intense strategic planning. We have an implementation team that consists of a medical director, a tumor registrar, program manager, and a few other key support personnel that meet with the hospitals regularly. We've done training and mentoring, both in terms of clinical training and then in terms of coordinator training and some of the CTR training. We've helped facilitate connections with NCI designated cancer centers to increase access to expertise and resources for the affiliate sites, and then also help them network with each other and really have appreciated the networking for what we learn in terms of how we can better support as well. So we're going to have our first in-person annual meeting next week with everybody, which we're very excited about. But we've had a number of meetings in between and virtual workshops. We have educational webinars on a series of topics from accessing genetic counseling and facilitating referrals for that to thinking about building survivorship care or palliative care resources within your cancer program. We've looked to do a bunch of quality improvement and data and methodologic support, because one of the COC standards is to be working on quality improvement projects in each cycle, and then really looked to increase ways for rural community cancer programs to access clinical trials. So we are now in the phase of, if we look at this slide, we've done the sort of top evaluation, the adaptation and fidelity of core functions, which took us from McCann to ICANN. And now we're really deep in the portion in this evaluation two of looking at how ICANN, which uses these external facilitation strategies to implement the COC standards as a goalpost, right? Something to work toward and measure by for rural affiliates. And I should note here that one of the key differences that we chose in terms of thinking about how we were going to adapt this is that we are not requiring COC accreditation on a certain timeline for our affiliate hospitals, but rather we are using movement toward the COC standards as a way for the hospitals to think and programs to think for themselves about how to improve their care over time and move toward more comprehensive cancer care. So our preliminary analysis, which we've just been completing, if you look at the 5 hospitals in terms of thinking across these different groups of COC standards, so one of the key standard processes is setting up cancer program leadership, right? Your cancer committee, and none of the hospitals initially had that in place. Now we have 3 who have met that standard, 1 who is partially met on that. In terms of tumor board, none of the hospitals were doing that initially, but they are. 3 of them are doing so now. They meet virtually, and often we have 1 member of our team meet with them as part of that. All 5 had made great progress on on data collection, and thinking about that tumor registry piece. We have 1 who is moving into specific quality improvement projects, 1 who has made progress, specific progress in terms of clinical services, and I'm thinking about hiring a specific role and using the participation in the network to leverage the ability to hire somebody, a nutritionist. A number who have started thinking about moving into survivorship. There's a great deal of interest in the provision of survivorship care across Iowa, but programs often, I think, are overwhelmed by the step that is moving to a survivorship program. One of the interesting things, though, is that as we've been working with them, is how many resources they do already have in place that that count as pieces of survivorship care provision. They're already doing so much in terms of that, and that's been fun to see. And then clinical trials, working on moving them toward that accrual goal by facilitating relationships with existing trials and trying to better protocolize information about available trials that might be good and appropriate for their patients. So as we've talked with members of ICANN, they've talked about some of the different barriers. When they look at the standards, they're all great things, but looking at them, but they're looking at someone who has a lot of services and a lot of things available to them, which these programs sometimes don't feel like they fit that model. And some of the challenges to accreditation, disbursement of the work, knowing that we have limited people for different roles, right? The Cancer Committee involves a number of different roles, and the way the commission has been set up is you can only have 1 person in so many roles, which was meant to sort of keep 1 person from having to do everything. However, in these smaller hospitals, you often don't have the staff to have roles split across the number of people in that way. Thinking about the benefits of working toward accreditation and being part of the network, on advocating for services, the dietitian is a wonderful thing to have in the clinic. And if we weren't pushing for something like this, could I have gotten that done? Maybe not. And then talking about the value of the data and seeing how they're performing compared to peers, and that as a group, right, it's going to improve quality of care across them. And then talking about the role of the network in general, about being able to leverage the larger resources of a health system or referral centers, thinking about building tumor boards or cancer committees and conversations across each other in terms of how to do that. And as this person says, the grant is valuable whether or not we meet accreditation or we don't. The information has been helpful. The information to me has been helping me push the program forward, which is exciting. So what have we learned so far? And I've only got a couple slides left. We've learned that relationship building is fundamental to creating trust and affecting change. Part of the thing I think we've learned across this is the amount, and it's unsurprising, I think, but the amount of time that it takes to build these relationships, to be able to make the change and bring the change necessary. Second, that size isn't everything. We are continually excited, impressed, and heartened by the resourcefulness and creativity of these cancer programs, how they work for themselves, how they work together in network. It's just really exciting. Like I said earlier, that success requires both senior leadership and physician buy-in, that really you have to get everybody sort of aligned in a particular direction. I talked about that critical access hospital earlier, who approached us well into the grant, but really has taken off. And part of the reason they've taken off is because they are really aligned as an organization on this goal of accreditation and of improving their cancer care for their community. Extending resources from an academic cancer center requires additional infrastructure. From our side, a huge portion of the work that we've done has been trying to figure out how to leverage the resources at our cancer center here at University of Iowa, and move those outward. And then the last is that implementation science is hard, right? The contextual differences, not only in moving this from McCann to University of Iowa Cancer Center, the Holden Cancer Center here, but also building these relationships with each individual hospital that changes over time, that's really a complicated task. And that's part of what makes it interesting and fun. But that's also part of what makes it challenging. Couple successes that we've had recently. The Commission on Cancer has recently announced that they're starting a rural accreditation track. And that's based on findings from our current grant and a lot of work from our grant team working with the Commission on Cancer. The rural accreditation track will be tailored to the needs and resources of rural hospitals. And part of what this will involve is an adaptation to some existing standards in terms of how they're met and the timeline on which they're met. One of the big things will be this gradual ramp up to accreditation, that you won't have to meet necessarily all of the standards. You'll have a core set that you have to meet, and then sets that you meet as you build on. And so that's really exciting as an opportunity to enable rural community cancer programs and hospitals to work toward accreditation and to incentivize that. The other piece that we've been working on is thinking about network dissemination more broadly. And part of that is trying to figure out the various models for cancer networks that are out there. There are a number of them throughout the country. We are certainly not the only. We are one of many. And so trying to figure out what sort of characteristics, what their compositions are, how they came about, what their goals are, how they set up their relationships with affiliate sites. We recently had a paper come out on that, and we're continuing to work on that piece of it as well. Nonetheless, we have a number of unanswered questions still that we look to continue to pursue. What standards are the most impactful for improving quality of care in rural hospitals? What is the interplay between network support, compliance with accreditation standards, and quality? Are there common qualities of successful networks across these different models? How do we best support local care while encouraging appropriate referrals for more complex cases? How do we create that sort of ideal referral pathway and relationship that the network should have, but still remains complicated? And what are the best practices for rural patient navigation? Our primary goal for this project was improvement in the quality of rural cancer care. We chose COC accreditation as our platform because it was the most comprehensive and well-established. We don't know whether some standards are more impactful for quality in rural hospitals than others. Furthermore, like McCann, we're using a network model to facilitate accreditation. And we'd like to understand more about how those two things interact. We studied McCann because it was the closest, but like I said, there's a number of other network models out there. So these are the number of things that we look at and questions that we have as we continue forward. And I will stop there. I have a series of acknowledgements, folks at the UK Markey Cancer Center, our whole team there, Dr. Charlton and everybody under the ICANN team, and then Sarah Birkin at Wake Forest University, who has been a wonderful resource for thinking about implementation science and that piece of it. So I will go ahead and stop sharing there. And I don't know if we have questions.
Thank you, Erin. That was a great presentation. So now is the time for questions. It looks like we might have a few. Well, there's some in the Q&A. But if you have questions for Erin, please put them in the chat box.
I have a question, Erin. It's Jacqueline.
Yes.
What kind of pushback, if any, have you gotten from rural hospitals as you approach them with the proposal to become part of this program?
That's a great question. I mean, I think one thing since this was a grant initially, we were able to offer them compensation to be part of the program for a while. In thinking about how sustainability models work for networks, often they require investment from the affiliates to be part of the network. So that's a question in terms of sustainability that we're thinking about, and that I'm sure, made participation initially more attractive, and we're thinking about, moving forward how to deal with that. I think the biggest challenges in terms of pushback are about time and resources, which is perhaps not surprising, but it does. There is an ask administratively, and especially on clinicians, to work toward accreditation and toward achieving these standards in terms of how reports are made, and the work of the Cancer Committee. And I think that's been one of the challenges we've had to negotiate. And then it's been interesting, even programs that were initially excited about it, going back to the slide, thinking about, places have one medical oncologist or one radiation oncologist. If that person leaves, that often sets their path, pauses their path for an extended period of time. And so that, I think, is a challenge that they have had to deal with and that we've worked to help.
Thanks for explaining. We have somebody put a question in the Q&A that says, I have read that distrust in the healthcare system is another cause of rural health disparities. Is rebuilding trust a consideration in your program? Do you think the accreditation supports trust or hinders trust as a part of the BIT healthcare industry?
Ooh, that's such a great question. And that's a really contextually specific question in ways that are really interesting, I think. So, thinking back to Markey, and the fact that in their cancer center, in the McCann model, they allow their affiliates to use their branding. That's in part because UK and the Markey Cancer Center have a really positive connotation across Kentucky as a healthcare system that is that is widely trusted, more widely trusted and respected. And so that was a really key thing that, like I say here, with the number of different healthcare systems, looks really different in Iowa. So I think our trust building has been primarily with the cancer programs to this point, and letting the cancer programs do that sort of outreach to communities, and promoting to communities, and reaching out in terms of prevention and screening and those sorts of things. We've supported them, I think, from behind, I guess I would say more. But I think rebuilding that trust is a key consideration in communities, and you have to be thoughtful about your context as to how you want to go about approaching that.
Thank you for that answer. We have one more question in the chat, which is, what challenges and solutions have you seen related to care, especially specialty care referrals across state lines, i.e. Medicaid and state licensure, when proximity to a major specialty center is in another state?
That's a great question. And I feel I think the places where I have seen that most, and I'm curious, I will tell you, Joy, I'm gonna bring that one back to the team, because I'm really curious what our medical director would say, and what the folks who work sort of day to day with the hospital teams would say. I have seen that in terms of thinking about some of the telehealth resources that may be provided from a place like Holden to a site. But I also think, you'll notice that all of our sites at the moment are within Iowa. And that was pretty intentional, I think, partially for that. And I think the other piece of that puzzle is thinking about data, right? If we're thinking about a lot of this based on tumor registry and what is collected, the state tumor registry data in Iowa is really different from what's collected in Illinois, Wisconsin, Minnesota, or Nebraska. And so I think that's another part that complicates it. We're working right now to partner with institutions in other places to move to other states. And I think we'll encounter that more then. But that's a great question. Thank you. I'm sorry I don't have a better answer for you.
There have been some great questions. We are approaching the end of the hour, so I'm going to share the evaluation link. But I want to thank you all for being here. And I want to thank Erin, Dr. Seaman, for presenting today. And Jacqueline's going to put that in the chat box. So if you can fill out this evaluation link, then you can claim your CE credit. We also have some upcoming sessions, including one on January 6th about implementing scalable exercise interventions, and one on March 3rd about a provider's perspective on building high-quality cancer care programs in rural areas. And I will give credit to Dr. Seaman that he has been behind this as well. So big shout out of appreciation, and thank you everyone for being here.